the fifth webinar, we will get the various government leaders from various.
Excuse me, sir. Excuse me, sir. Sorry, could you just try to mute the mic, because I mean the camera, because we are not hearing very well. It's like the network, either you're not positioned well or the network is not circuit.
Right, is that a bit better? Is that a bit better?
Okay, let's try.
Yes, that's better. That's better.
Not really.
Is that better, Nyambo?
Yeah, it's a little better. Let's hope it holds.
Okay, I'm going to. Is that a little better now?
Yeah, that's better now.
Okay, great. Thank you. Once again for the introductions. I think the numbers are increasing. We have just over 60 people now in this webinar. And of course, this is webinar number 2 of 5, as Jacques has indicated. And in this particular webinar, we are looking at an exploration of evidence-based service delivery in the times of COVID-19. And I think as I start, I think I would want to just say that we have, of course, as a globe, stepped into a new world order. And in March sometime, we left the world behind us and we stepped into a completely different world, a world where we have to do things completely differently, and the world that we left behind is the world that we are trying to get back. So this is the new world order that we are in right now. In this particular world, we have been forced to adapt to what has become commonly known as a new normal. Also been forced to be much more agile, and our systems have been tested, the efficiency rather of our systems has been tested to be able to respond to shocks such as COVID-19. So this is a very different time to what we previously had. And I think the pandemic has certainly affected and impacted on our livelihoods and disrupted national economy, and of course the social fabric of creating a worldwide fear and uncertainty. It is at this time establishing a new order, as I indicated, and disrupting global public health governance systems, and thus public affairs as we know, or knew them rather. Now, I want to welcome everybody to this platform, and we're meeting in this manner mainly because COVID-19 is also reordering how humanity will be interacting with the world we live in. It is also demanding of the institutional arrangements that we have that respond to COVID-19. Of course, how the pandemic will unfold and the manner in which we adapt specifically to those changes that we are basically compelled to. Now, population dynamics and by way of implication, demographers are important to any development strategy that a country needs to implement. And we have seen different trends in our region as the African continent on how COVID-19 impacted our society. There has been greatly varying rates and epidemiology. Epidemiology of the virus has differed from country to country. Some are using, some are rather decline in infection rates, while others are at the onset of emergent infection. And this is so-called second wave. Regardless of the numbers, though, and scale that our countries face, what is uniform is that in times of disaster, the poor and marginalized bear much of the brunt. As South Africa, we've had to implement unprecedented measures in terms of social and economic measures to really try and push in the most vulnerable poor in society, but also for businesses to ensure that they approach against the pandemic. So the aim of today's session is really to focus on delivery of primary services during COVID-19. We will begin by reflecting on our last session that we had last week, and then address service delivery from health and demographic sites. We'll further look at challenges and service delivery and adaptation using Uganda as a case study. We will then look at both the government management as well as the medium to long-term impacts of our response using Malawi in this regard as a case study. And I think what we've had to do, not just as government, but also sector, but more so government, we had to really rethink about the way we do things, as I initially indicated. We've had to automate, find ways of using technology in a much more efficient manner. We've had to automate our systems and move towards digital solutions in terms of delivering our various services to the government. We've had to do this whilst ensuring that we prevent the spread of the virus or the pandemic, and indeed in keeping with the various protocols in that regard. So we want to once again welcome everybody. I believe that we have a number of member states from the African continent that are part of the discussion. We want to thank and also welcome the academia and think tanks that are with us today, and of course government and civil society information. Yeah, straight to it. We have a series of speakers. We have 5 speakers size, and as I indicated, Mr. Nompumelelo Nzimande from the University of KwaZulu-Natal will give us the reflection on webinar number 1 that we had. What we will try and time by all means. So, speaker will be given 12 minutes to speak, and I have a stopwatch in front of me, a very big stopwatch that I will be using to make sure that we stick to time, and we will politely stop speakers as soon as they go beyond the 12-minute mark. The second speaker will be Mr. Kobus from the African Health Research, and he'll be speaking about the evidence of the impact of COVID-19 on service health, demographic surveillance sites. The third speaker we have is President the Wish to Action Program, reproductive health in Uganda, and she will be talking around the challenges of service implementation during COVID-19 in Uganda. I will do this one by one again as they come through, by way of ensuring that all know profiles and summarize that. Our fourth speaker is Joseph Ngoi from Malawi, National Planning Commission, and he'll be speaking of medium and long-term impacts of a moderate lockdown, social restrictions in response to COVID-19 pandemic in Malawi, in response to cost-benefit analysis. And we'll have a last speaker, Ngani Matomela from the UNFPA, and he'll be speaking around governance and service delivery in response to COVID-19. We will have a discussant who will, after all the speakers have spoken, for about 3 minutes, and that's the Nasian guy, and he's president of the UAPS. So immediately after that, what we will do is take questions. We have a chat box, which we encourage everybody to send their questions through, so that we are able to flag those quickly and respond to them accordingly. We will try and manage time in this regard as well, and also give an opportunity to those who are not able to flag those questions in the chat box to raise their questions, input, comments. We will appeal participants trying to get as short as possible and stick to the point, so that we have an opportunity to give everybody a chance to ask questions in this regard. So, without, if I may, ladies and gentlemen, once again, welcome everybody, and let me introduce Mr. Mkhanyakude Mande, who's a lecturer and demographer, rather, as well at the School of Built Environment and Development Studies at the University of KwaZulu-Natal, and is an academic leader for disciplines of population and development studies. She holds a master's in sociology and population studies as a major from the University of Health, and a master of demography University of Wisconsin, Madison. She's a member of the Council of South Africa and chairs the population and social sub. She's led research projects that grade population demographic dividend and migration plans, and have theories of determinants and consequences of population change, demographic aspects, family formations, and demographic dynamic for the area population. Ms. Mande, we want to welcome and give you the opportunity to speak to us, providing us questions on webinar 1, and we will give you about 12 minutes to do so, whilst we welcome additional participants or attendees to this very important webinar. Thank you very much once again. At this point. Thank you.
Thank you, Chair. Good afternoon, colleagues. Good morning and good evening, depending on where you are. My task today is to give a reflection on the webinar that we had last week, which focused on the demographic impact of COVID-19, and attend more to also interestingly focus also on the impact on the demographic dividend as well, or the prospect of countries' ability to yield positive reward from that. One of the first discussions that we had was recognizing that the shape of the transmission of the pandemic has already a demographic element to it, where we discussed that age and sex and socioeconomic status are critical components that determine who is likely to have the worst outcome if infected by the pandemic. The webinar explored how this differential impact is seen in different countries of the world. We also saw specific case studies in Africa and more specifically in South Africa as well. This linked to us discussing a bit on why Africa is having lesser numbers of COVID-19 infections and also lesser mortality linked to the pandemic. This was an interesting discussion because this has come up in different spaces, and a lot of issues came up on that related to discussions, failure to counting deaths, which is closely related to data issues. Another explanation may have been early decision regarding governments closing lockdown measures and also mask wearing and other various public health responses that Africa may have benefited from, some of which may be about Africa having experienced some of the previous pandemics and learned from it, and also maybe there may be protective immunity in the African continent based on the BCG vaccine. Many large populations haven't received the vaccine in the past, or also there may be genetic explanations. So these were raised in the discussion last week. However, the most compelling yet evidence that was offered was that Africa's age structure may be a strongest impact that may drive why we see lesser levels of the pandemic in the continent. With that, we moved into discussions regarding what are the possible pathways of impact of the pandemic in the continent. In that space, it was quite interesting to listen to how the presenters had a very demographic lens on and using what demographers already have in their toolbox in terms of already known determinants of demographic dynamics. And a lot of those were us looking at, presenters looking at what is the possible impact on fertility, mortality, and migration, and also what is the possible impact on age composition, looking at frameworks that we already are aware of impact. What came up from those presentations and discussions is that the proximate or more immediate impact factors may not necessarily be the main drivers of the overall impact of the pandemic. What may be a bigger impact actually may be more distant factors. In this regard, the factors that we need to worry about are those that have also been discussed by other areas in terms of other disciplines, and those are linked more specifically to the interruption of education, for example, access to healthcare, more specifically including family planning. We actually had evidence shown that because of COVID-19, some populations have not been able to access general package of sexual and reproductive health, which would have both an immediate and a long-term impact on the pandemic, and also adverse impact from disruption of economic activity, or will have an impact of in all the demographic indicators, but more based on the linkages that it has in socio-economic well-being of populations, both also micro and macro effect. Key concerns that emanated from last week's discussion set on how COVID-19 may deepen already existing poverty and actually widen inequalities that already exist. I mean, one of the issues that were discussed were how this would impact on education specifically. Educational gaps that already exist may be wider. Some already population in poverty may not explore all the existing technology in terms of exploring online learning and other existing COVID-19 learning platforms. And what would this have due to educational gaps, and therefore how would this in future impact the well-being of the teenagers, and also therefore on their educational outcomes and other demographic outcomes. One of the key aspects that sort of were cross-cutting in the discussions were that of data. In fact, one of the presenters indicated in one of their slides that one of the major challenges that we're going to face as a demography fraternity is the lack of timely, good quality data. And so I wanted to go a bit deeper on this discussion with the limited time that I have in outlining how this is going to be very critical in driving both our understanding of the pandemic now and understanding the long-term impact of the pandemic. Demographers can contribute quite positively towards the ability to map the data and also monitor continuous progress in the pandemic. The issue that is currently worrying all governments is understanding the current impact, understanding the infection levels, recorded deaths, and the chain of transmission and vulnerability, which everyone in governments are trying to do right now. Concurrently, what should be of concern, or what we should be working on, is assessing the data ecosystem to see whether it's conducive for current, midterm, and long-term in assessing the impact of the pandemic. This would include looking at the data collection platforms, for example, existing or upcoming surveys, national surveys, whether are we working towards including COVID-19 modules that would help us assess the impact of the pandemic and in a much more overall sense. But also 2020 round of censuses, we know that a lot of countries have not been able to have their censuses this year, but are planning for them when the pandemic has passed or is under control. Whether within those, are we in a position of thinking of how we can include ways in which we can COVID-19 module. What would be, we know that I'm happy that we have a demographic surveillance system sites with us, and I'm sure that with the longitudinal data, there are already plans. So those are the data kind of platforms that are critical right now, because not only are we to understand the pandemic now, but the long-term impact of the pandemic. It would be a shame to reach a point where we cannot do that because we had not prepared data for that particular space. In this, I would say countries should be lobbying their governments to recognize the importance of data in understanding not just the current impact of the pandemic, but the long-term impact. But specifically, the National Statistical Offices should also be looking into already existing data. Unfortunately, this is existing at a time of economic constraints, where some of the surveys and are being cut because of economy. But I think the time is now for, unfortunately, demographers to lobby and indicate the importance of data, that without data we will not be able to understand the full impact on COVID-19, both into the demographic impact, but also in a wider societal space. We will not be able to locate vulnerable populations that are greatly affected by COVID-19 indirectly, because direct or heartfelt. Thank you very much.
Well, thank you once again, Ms. Nzimande, for that very insightful update. Can we ask everybody just to mute, please? Ms. Gertrude, you are not muted. There we go. So thank you once again, Ms. Nzimande, for that very insightful input around the reflections on the first webinar. And I think a very critical point to take home there is the importance of data and in understanding, of course, the impact of the pandemic, but also the fact that data serves as evidence-based research, or contributes towards evidence-based research, particularly for future policy making, but of course, most importantly, to really understand the impact much better utilizing data. So I think that's a very important sort of platform to build on as we move into today's sessions, and of course the other elements that the speakers will speak to. That was also very quick. I think you did that in less than 10 minutes, so we want to thank you for that. Maybe as we go forward, what I'll do is, as soon as the speakers see my face, they must know that they've got about 10 seconds left, and then we will then move on to the next speaker. Let me introduce the second speaker at that juncture, who's Dr. Kobus Herst, and of course, he's a director at the Department of Science and Innovation funded SAPRIN, which is South African Population Research Infrastructure Network. And of course, SAPRIN is hosted by the South African Medical Research Council and funds the population and health surveillance at 5 nodes in about 3 different provinces, or 5 different provinces rather, in the Western Cape, Gauteng, KwaZulu-Natal, Limpopo, and Mpumalanga provinces. He's a faculty member of the African Health Research Institute and the principal investigator of the Population Intervention Program, better known as PIP or PIP. And in addition to his duties as the Chief Information Officer at AHRI, where he is responsible for ensuring that information governance and management at the Institute supports and enhances its research mission. He is an honorary associate professor at the School of Public Health at the University of Witwatersrand and honorary professor at the University of Limpopo. Professor Herst, let me welcome you as you render your remarks, sir, for 12 minutes. And we're looking forward to hearing from you in this regard. Thank you very much, Prof. I think the presentation is also on the screen. Let me hand over to you now, Prof. Thank you so much.
Thank you, DG, and thank you for the invitation to this webinar series. Greetings to colleagues on the seminar. I'm going to talk to you about the evidence on the impact of COVID-19 on service delivery from health and demographic surveillance sites. As the DG said, SAPRIN is a network of sites in South Africa, and we have 3 established sites. And the data that I will be sharing with you come from these 3 established sites in Mpumalanga, Agincourt, Dimamo in Limpopo, and Ari in northern KZN. The 2 sites in Gauteng and Cape Town is brand new, and we are in the process of starting them up. So SAPRIN is part of the national research infrastructure, and it's a population platform to provide multidisciplinary research evidence and to inform health and social policy and programming. It looks at poor rural and urban communities, and each node follow at least 100,000 individuals in approximately 20,000 households each. The COVID surveillance that I will be talking about as the core source of this data is from our routine surveillance, where we each node visit the 20,000 households in a 15-week cycle. So making contact with them once every 15 weeks, and also an additional high intensity sample where each node contacted every 2 weeks a randomly selected sample of households of at least 750 households, and you can look at the detailed protocol in that publication that I've listed there. So we were, and I think, and I'll come back to this, is that the fact that we had this infrastructure established allowed us to respond very rapidly to the epidemic. So within a couple of weeks of the state of disaster being announced, we had our protocol developed and received ethical approval, and we changed our surveillance that consists both of physical visits to households and telephonic contact, 1 physical visit, 2 telephonic contacts. We changed that to just telephonic data collection, and we introduced this COVID surveillance at the same time. So in Agincourt, they started in mid-April, so literally within a couple of weeks of the first cases being reported in South Africa, and then you can see how over time all the other nodes joined, and that we have this longitudinal view of regularly going back to households and looking at the impact at household level and at individual level of the surveillance. In this presentation, I'm going to concentrate on the service delivery aspects, and we have a publication under development that we will be publishing shortly that goes into more of the detail of the other household achievements. This graph shows when the number of cases really picked up in those 3 provinces. And so it's during this advanced level 3 lockdown that these things happen. And we are reporting on data up to the end of August this year. In fact, up to the end of September, this is a summary of the total surveillance that we've done. We've interviewed almost 50,000 unique households, 50,000 household interviews. We screened about 150,000 individuals. We identified just over 1,000 individuals that are possible COVID-19 suspects. We tested 580 of those individuals, and we found just 64 COVID cases. So the actual impact of the pandemic in these communities were relatively low. Of course, with a sort of a surveillance where you speak to a certain number of households on a particular day, given the short duration of the actual symptoms, you are likely to also miss a lot of cases. So this is by no means the total number of cases that were exposed or contracted the disease in these populations. I should just be clear about that. We will really only know the true picture of the pandemic in these communities if we are able to do a serosurveillance, COVID-19 serosurveillance on the total populations within these nodes, and something that we hope to do. Moving on to what we found recording access to health services. So actually quite a large percentage of households, just under a half or just over a half under certain circumstances, reported that one or more household members missed a medication or were not able to access medication that they needed during the preceding 7 days. What is actually interesting here is we see that at the start, during the heavy lockdown, lack of access was higher, but that also worsened. It improved, but then worsened during July when we had the major impact of cases, as you can recall from the previous graph, in this case in KZN and Limpopo. And we think that may be due to some closures of primary healthcare clinics because they had outbreaks amongst the healthcare providers in those clinics, and the clinics were closed. In terms of reporting inability to access healthcare, that remained relatively low over time, but definitely there was still some impact, and we saw again a hint here of worsening during July. Now moving on to, so that was the perspective sort of from the households themselves, what they were reporting. Now I'm talking about if we look at the actual visits to the clinics that are servicing this population. And here I'm looking at 11 clinics within the Hlabisa sub-district, which is the sub-district where the RE surveillance takes place. We record every visit to the clinic and link that to the population as people attend the clinic. And here we look firstly at a regression discontinuity analysis, and you can look at the detail of this analysis. It's just been published in the British Medical Journal, and the reference are at the bottom here. So although we didn't see a significant discontinuity at the time of the this is the first lockdown introduction, there were differences in different services. We see a clear and significant discontinuity in child health services. The number of visits for child health services, vaccinations, etc., during the first month or so of the lockdown, that improved over the course of time. We see a slight increase in HIV visits to the clinics, and I will come back to that in the next slide. But didn't see any difference in perinatal care, family planning, nor differences in chronic care visits to the clinics. The effect that we saw in child health is mirrored in the age breakdown, where for under infants and young children, we also see this very clear discontinuity across the moment of lockdown in these clinics. When we look at laboratory tests clinics in the Mkhanyakude district as a whole, which is the district in which the RE node falls. There are some interesting effects, and here we compare data from 2018, 2019, and 2020. And we can see here, and in terms of the number of gene expert tests, that is diagnostic tests for TB, that definitely declined over the period of lockdown, although the positivity rate did not show a same discontinuity across the lockdown period. We saw actually a significant increase in HIV viral load tests being done, and no real difference during the lockdown period in the viral load suppression rate. We speculate, and we don't have direct evidence of this, but that it could be due to two reasons. One, during that time, there was a switch to a new medication, dolutegravir, and people were asked to come to the clinic to switch, and at that time, a new viral load was done, and that may be probably the cause of it. It could also be from other sources. We know that there were quite a bit of movement of individuals back from urban areas to the rural areas, and that they would then visit the local clinics to establish their ability to get treatment at those local clinics during the lockdown period, and that may also be a reason for this increase. Then we should establish longitudinal population cohorts can rapidly respond to the pandemic, and that we can look at health service delivery impact both from a population and health service perspective. And it's also important to consider both the population and the health service perspective, because they may differ and provide us with additional insights when we compare these two. And I want to refer back to Nompu's presentation before me, that I think another important feature of this information data resource that she stressed is the ability to look at the impact of the pandemic over time. 3, 4, 5, 6 years down the line, we may be seeing late effects, and these demographic surveillance populations may be the only places where we have the ability to, in a well-defined population, look over time. Thank you very much.
Thank you very much, Dr. Hurst. You were exactly 12 minutes and 30 seconds, but thank you very much for that presentation. Very useful indeed and very helpful. I think you also demonstrated in that presentation the value of surveillance data as evidence to inform service delivery, and of course some of the local post-lockdown trends that were presented give rise to concern. For example, in the area of child health, and I think also acknowledges the fact that during the lockdown, it became very difficult for access to healthcare services, even though it is considered as an essential service, because people feared in most cases that some centers were also forced to be closed, etc. So it did certainly have an impact in that regard. But I think the presentation also puts forward a number of hypotheses which we should further explore, both at national and, of course, within the continent. But thank you so much for that very insightful presentation, Dr. Hurst. And of course, we will hear later from the discussants some of the areas that touch on some of the areas that you've raised within the presentation. Let me now take the opportunity to welcome Dr. Annette Nagudi. Dr. Nagudi is the Ugandan Project Director for Wish to Action program at the Reproductive Health Uganda, and which is one of the flagship sexual reproductive health programs supported by the UK Commonwealth Development Office, being led by International Planned Parenthood Federation, and of course RHU is one of the member associations, which is part of the International Planned Parenthood Federation. Dr. Nagudi brings to the table a wealth of experience in public health programming and service delivery. I want to welcome Dr. Nagudi, Karibu, Dari, Annette Nagudi. You are on the floor. Thank you very much.
Thank you, and it's an honor to be here and to present our experience of COVID-19 as an organization, and which partly touches to the country. Should I share my screen, or you're sharing from your side?
Okay, I would suggest that you share, Doc. It may make it easier for you to flow in the presentation.
Okay, thank you, and just confirm that you're able to view my screen. I've shared it.
Perfect, we can see it now. Maybe you can try and just slideshow the actual presentation so it appears a lot bigger.
Okay, should be. Okay, is that better?
100%. Thank you very much, Doc.
Thank you very much. Again, it's an honor being here, and greetings from Uganda. It's an honor to share our experience with COVID-19 in the country. And briefly, I know you've introduced extensively RHU, volunteer or non-organization that champions universal access to rights-based SRH, sexual reproductive health information and services. We're a member association of IPPF, as rightly mentioned, and we have a countrywide operation in Uganda. We operate 20 static clinics owned by RHU. We support 50 social franchise facilities, and we also do support some of the public facilities. We partner with both public and private, as already mentioned, public and private through the social franchise model in delivery of the SRHR services. Briefly, I will also touch a little bit on the epidemiology of COVID-19 in Uganda, which I know a number of you may have or may already know that the first case was registered in March 2020. After a long struggle of trying to ensure that we keep COVID-19 out of the boundaries of Uganda. So we registered that first case, and to date we do have 11,443 confirmed cases in the country. Out of those, 7,676 are so far recovered after treatment, and we've registered by yesterday 100 deaths with a case fatality rate of 0.9%. Now, at the moment, 88% of our confirmed cases are local transmission. We started in with imported cases, but right now we are in the middle of a community transmission. So 88% of our cases currently are from local transmission. And from all the samples tested so far, our sample positivity rate for COVID-19 is 6.9%. Go straight a little bit to some of the challenges that COVID-19 posed. Now, this is kind of skewed towards service delivery, and again, specifically SRHR, and that is what we do as RHU. And under that's a framework under which the Wish to Action project is being implemented. So at organizational level, we had limited reach to our clients, both at static and outreach posts. That is starting right from the time the first case was announced and we went into a lockdown. And the limitation was mainly due to restrictions in terms of movements, restricting public gatherings, and then also general public fear due to the announcement of the first COVID case. We also had a challenge of limited supply of equipment and supplies for service delivery, definitely with the restrictions on transportation. We had issues with the supplies. Overall, we had limited adherence to government putting both within RHU and then within the communities as well. And this was basically due to lack of general awareness of this new, disease that had come on board. We had increase in the cost of service delivery because we then needed to now spend some more money on infection prevention as well, and then juggle through to ensure, access to our clients. Beyond RHU, the community experienced challenges. Again, limited access to service delivery points. We were saying they are not coming, but they're also saying we are not getting the service. And that was again because of the restrictions and the fear. Limited access to information, beyond the rumor that now we have the new disease, but how many were accessing, information? That was a big challenge at community level as well. There was political entanglement amidst the pandemic, and this was really due to lack of trust, where people, certain sections, okay, it's a lie, it's not the truth. The government is trying to bring this because the elections are coming our way. So it's a big challenge that people actually fail to trust at first, say yes, COVID-19 is real. And then at community level, now everybody was locked down there, and we had an increase in gender-based violence being reported. Challenge now from community and organization, we have the overall now big challenges. We had increased demand for SRH services because people were locked down, they were engaged in sexual activity. However, with limited supply, because people couldn't access service delivery points, but also general equipment and supplies, access to those were also limited. Increased cases of unplanned and teenage pregnancies. This is one of the biggest challenges I think that COVID-19 will leave in the country, because people were locked down there. The teenagers were out of school and now they were home. With the limited parenting in place, cases of teenage pregnancies short. It is unfortunate that I may not present the statistics here, and it's something that we are still, documenting at length. Hopefully that there will be an opportunity to present this in future. Of course, with the unplanned pregnancies, increase in cases of abortions, and these are from the DHIS2 data from the health facilities, but also from our very own data quality audits that we do in the supported facilities. And of course, the biggest challenge of risk of the spread of COVID-19 with the limited adherence to SOPs, but also inability to afford some of the protection that was required of COVID-19. Now, with those challenges, and again, keeping it within SRH, because we will talk of, for example, challenges of now young people moving away from school and getting home. Those, are areas that have not tackled here. What are some of the service delivery adaptations that we had? We quickly went into planning. Remember, we are donor funded. We have commitments to the donor, but beyond, we have a mission in place. So when the lockdown came, we needed to think quick. As an organization, we developed SOPs to guide continuity of service delivery, especially the community outreaches that pull usually big crowds. And these SOPs were developed in line with the government requirements. We realigned our budgets, and thanks to donor flexibility, to allow for procurement of protection, equipment and other supplies. We went ahead, procured, personal protection supplies, the protective gear, hand washing facility, disinfectants, and of the like, to ensure that both our service providers, but also the supported facilities have access to these and they are protected. So that to some extent facilitated continuity of service delivery. We set up virtual platforms. Now, these are some of those that were barely unheard of because we're used to physical meetings, but we had to think quick now, how are we going to communicate in a big team? And by the way, in Uganda, the Wish to Action project covers the entire country. The one under RHU alone is in 6 regions. We cover about 150, health facilities that we support under government, plus the 50 franchise. So it's a big coverage. We need platforms to coordinate the supported partners. And then we went into, we decided to make our review meetings more frequent. Now, in the center of all this, since we had so much restriction, we had to seek clearance for vehicle movements. And thanks to great collaboration with local leaders, it worked wonders that within 3 days of the overall lockdown, for us as a team, we were able to restart service delivery and move out on a daily basis. We implement up to about 3 outreaches per region of what we call a cluster per day. So that clearance, opened doors for us to be able to reach our clients or the intended beneficiaries better. Now, within demand creation and community mobilization, we also had some adaptations made. We focused more, since we focused more on reaching the poor communities, we were more focused at IPC, the interpersonal communication. But now we realized, if we cannot do door to door and then call for gatherings to conduct dialogue meetings, we focus now more into mass media, and we had to change strategy to use more of the radio spots, but now integrating both COVID-19 messages with routine SRH messages that we used to air out there. So that there was a bit of shift from interpersonal communication to general mass media. And then we deployed megaphones. That was the only way people would get to populations that have no access to radios to listen to the radio spots. Now towards, of course, this happened in phases, towards the easing of lockdown. Now, again, we go to waiver now to start conducting dialogue meetings, but of course, with a focus on ensuring adherence to the national SOPs, social distancing, and then the use of masks. Now, they are just showing you some of the photos there that was the young people there in a radio talk show when we were hit with the escalating numbers of teenage pregnancies. And then there is a van there with a megaphone combing the community to mobilize people and say, yes, we are still providing services, or when we have a planned outreach, they are informed of where the outreach would be. Now, we also had adaptation in regards to service delivery. To ensure that we minimize lost opportunities, we expanded our service integration scope. Beyond family planning, we offer in a package of services. I realize the time, and let me wind up quickly. And so we included in GBV to ensure that now we are addressing the GBV cases. We enhanced infection prevention through the protective gear for the service providers. And we kept controlling the numbers in our service delivery points to avoid overcrowding, to be in line with the government SOPs. We had to some extent some capacity building, especially on infection prevention and quality of care, to ensure continuity within the period of COVID-19. And then we picked out on Cyanapres, the self-administration of DMPASC, the subcutaneous injectable family planning method that a client could pick and then self-administer at home, just in case there's lockdown again. So we had to do this training quickly just to prepare for what would come next. And then, of course, training on identification and management of victims of gender-based violence. We had to enhance our coordination and partnership with the governments, put our teams in all the task teams, both national level and at district level, to ensure that we are in line, tandem with the government on what is going on, and to prepare our teams to continue service delivery. And of course, to support the district COVID-19 response activities. We integrated with the districts as much as possible, especially, for example, in dissemination of messages, to ensure value for money, whatever limited resources are there. If you're going to talk about COVID-19, talk about SRH. So we had that integration, and the teamwork helped us a lot. Now, within the organization, to ensure enhanced control of the pandemic, we set up an RHU-specific COVID-19 task team that was to guide the operations of the organization. We developed SOPs specific to the organization and built the capacity of the teams on surveillance and management of COVID-19. We ensured that we set up screening points at all our service delivery points, and with an isolation point, those that are asymptomatic. And we ensured that we had a team that could manage whatever cases of COVID-19 that we would get. I will not go through the experience of our service provider because of time, but just to mention that as an organization, we ended up to date we've registered 4 cases within the organization, and we've been able to manage them, and 1 has fully recovered. The 3 are on the way to recovery. And with that, colleagues, thank you so much. Over to you.
Well, thank you very much. Asante sana, Doc, Dr. Nagudi. Thank you very much. That was very insightful. And I want to just sort of latch on 2 things that you said. One is the ripple effects of people having to stay at home, and particularly young people, and the impact that has come out of that, or rather the negative impact around high teenage pregnancy, unsafe abortions, and of course the increase in demand of services. One of the other things that you mentioned is just fundamental, is the fact that we've had a massive increase in cases of gender-based violence and femicide, and this is largely because people are at home, and of course when people are at home, it becomes more difficult for them to come out and report cases, etc. But I do think that it's a fundamental thing. In fact, in South Africa, what the president has moved to do is to highlight that gender-based violence and femicide is actually a second pandemic after the first pandemic of COVID-19. So I think that's a fundamental thing. But maybe the other very important element which I want to highlight, and I suppose I will try and come back to it at the end, is the fact that the value of these discussions are really I mean, they're really important. We're able to get a sense of how other countries have managed through the pandemic, and I think some of the innovative examples that you used, particularly in terms of reaching communities through communication, various communication measures to spread the message, are really are important for us to take note of, because in South Africa there was a slightly different approach. We focus more on social media and so on and so forth, but I think it's a brilliant sense. It's good to get a sense from other countries as well. But I think the fundamental thing that we should draw from that, Doc, is the fact that we are at risk of a second wave. And because we're at risk of a second wave, we need to consistently ask ourselves the question, what lessons have we learned from the first wave insofar as service delivery is concerned? How will we respond much more effectively, much more robustly, much more agile if the second wave is to come? So are we going to be doing the exact same thing that we did during the first wave? There should be a sense of improvement in all our services. So I thought it was important that I just tap onto that very quickly. I think we're doing good with time. I'm going to quickly run to our second to last speaker, who is Mr. Joseph Nagoyi. Thank you very much, Mr. Joseph. You'll note that I'm trying to speak in your home languages, and I'm struggling here. And you know, I got it right with the doc. I may have a challenge with yours, so we'll see how we go with that. But as we introduce Dr. Nagoyi, of course, he's a director of knowledge and learning in Malawi at the Malawi National Planning Commission. He's a social scientist and has worked on a wide range of social economic research projects related to agriculture, fisheries governance, and climate change adaptation. Dr. Joseph also holds a PhD in rural development, in anthropology to be specific, and has published widely his work. And so we look forward to hearing from you, Doc. Again, we'll give you 12 minutes. Let me hand over to you now. Thank you very much.
Thank you so much. Let me try to share my screen. Okay. Are you able to see that? No?
Not yet, Doc.
Okay. Yeah, maybe if you could share from there. I think I'm probably having a problem to share from here.
Okay, we'll do that. Let me suggest, Doc, that perhaps you start, and as we go through, Mr. Onyango will assist us and the team in this regard.
So thank you so much and welcome. Good morning, good afternoon, and good evening. I'll be speaking on behalf of my colleagues. Unfortunately, I was not part of the group that did this study. What I'm going to present is basically looking at medium and long-term impacts of moderate lockdowns, social restrictions in response to COVID-19 pandemic in Malawi. This was basically a rapid cost-benefit analysis. And it was basically my colleagues that, as I said, did that on behalf of National Planning Commission. Basically, National Planning Commission is a new institution that has been just been put in place, institutionalized, to take care of long-term development planning. So currently, we're developing a national vision for the country, which will run up to 2063. But apart from that, we are also mandated to ensure coordinating implementation process of the vision. And so I think this is basically what the national planning is all about. Can I still have the... So while we are doing that, the presentation, basically I will put up, I will speak about the background to this study and look at what areas we focused in terms of analyzing and few results and also the recommendation. Just to say that in terms of background, this assessment of the medium-term opportunities and also it also delivered resources towards addressing the COVID-19 pandemic. And we had a contribution support from Copenhagen Consensus Center and also the African Institute for Development Policy. Just also to say that the recommendations from this study should be considered in the text of that this is a rapid changing epidemiology, economic and also information environment, and are basically on the information that we had by early May 2020. So what are the focus areas? In this brief, we basically considered the opportunity cost of closing schools as a measure against the pandemic, but also movement and livelihood restrictions, social distancing and other things, but also looking at what other impacts could actually COVID-19 affect in terms of other diseases, healthy diseases that communities always face, like HIV/AIDS, malaria, and other things. So the analysis considers these measures to last for 9 months, and this paper uses 8% discount rate, which is based on the guidance provided by Robinson. So this way, as I indicated, is basically getting from existing information as of May 2020. So when I think I would want to look at these two graphs, if you're able to see them. There are basically two graphs there where Cooper and Smith did in early 2020 in collaboration with the Ministry of Health, where basically they modeled on what are the impacts in terms of infection and also death on areas where you have no mitigation or you have no further reduction from the current scenario. But also if you are instituting additional guidelines in terms of mitigation of about 30 to 60. So if you can see, there are those red lines and green lines and blue ones. So the red basically is where there is no mitigation. And the blue one is where you have enforced some population restrictions for a reduction in mobility. So under unmitigated scenario, the expected deaths in Malawi were modeled to be around 37,000, assuming an R of 3. So introduction social restriction measures, reduction social contacts by 45% leads to only about 25,000 or 25,575 to 28,000 deaths, for a net benefit of around 9,000, 12,000 avoided deaths. So that's basically, if you combine these two graphs, what it's about to say. So we also looked at, as I indicated, the impacts of other non-COVID-19 deaths, looking at the impact of HIV/AIDS, TB, malaria, and basically what that table is showing is that the overall moderate socio-economic restriction would actually increase death by about 4,000, over 5 years, through which mixed impacts across the disease. And HIV/AIDS are lower by 3,000. So HIV/AIDS death would actually be lower, while there are 4,000 and 3,700 more TB and malaria deaths respectively under moderate restrictions. In terms of the net health benefits to the opportunity cost of the school closure, basically what you are seeing here is that there are more costs actually to closing schools than the benefits you get from I think from reduction in terms of death. Basically, as you know, I think once you disrupt school
let's remind colleagues to please mute. Ms. Betty, please could you mute? Go ahead, Prof.
So the issue here is there are so much cost in terms of closing schools, because once you disrupt school curriculum, actually the effects cannot be observed immediately, but they are longer term. You take more time basically to make sure that I think those costs are done, or maybe you may not recover at all. So the opportunity cost in terms of the loss of future incomes from school closures clearly outweighs even the most optimistic estimate of the net mortality benefits. When we look at opportunities in terms of cost of movement and livelihood restrictions, so these restrictions were basically in terms of closing markets. It could be closing markets that were actually being put forward, closures on non-essential businesses, partial limits on casual activity, limiting public gatherings, and limiting public transport. So we again see that I think the benefits when you put up those restrictions basically lower than the costs I think that you are going to incur in future. So the net health benefits of moderate social restriction policy would be the order found in section 2 would be about 6,000 avoided death, and this should be compared to the opportunity cost of lower economic growth rate of about $6.7 billion. That's the loss you get in terms of GDP. So finally, I would want to basically to just include what I've been saying is presented in this graph. So these social restrictions basically result in GDP loss, education loss, but also additional mortality costs. But when you look at the mortality, basically you don't get much in terms of that. So in terms of conclusion, what we basically concluded from this kind of work was to say that the government basically had a very big decision to make in terms of what to do basically in terms of should they lock down, the balance between locking down, but also to contain the COVID-19 and also the cost, the benefits and costs that are going to be generated. So in terms of recommendation, what this paper recommended is that we need to do social restrictions, but do not increase social restriction more than what is already in place. At that time, they had just closed schools, but also put other measures of social distancing and others. So, but they were yet to implement, the government was yet to implement other social restriction of actually having a permanent lockdown of the country, which this basically this advisory piece told them that I think it would better stay in what we were doing that time. I think to avoid mass livelihood disruptions in other countries. The other recommendation was to mitigate education loss and open schools when possible. As I indicated, schools were closed that time. So the issue was if we continue closing schools, I think the losses would have been far much bigger. So we needed to start opening schools, especially starting with those exam classes. And I think this could be staggered in terms of operationalized so that we also observe the social distancing. So the final recommendation was basically to look at, we need to keep key community health service funded operating, because the issue was maybe we could emphasize more on the COVID itself without actually also making sure that we have other diseases that we needed to manage. For example, TB, HIV/AIDS, and malaria. So these needed to be also continued while we are looking at making sure that the COVID is contained. I must say that I think once this recommendation went to government, what happened was the government actually used this piece of work to basically inform them in terms of managing the COVID-19. So the government instituted a task force, which was known as Presidential Task Force on COVID-19, and they picked some of these recommendations to make sure that I think in management of the COVID-19, as I'm saying now, schools have now opened slowly, I think starting with the exam classes, and the other classes started last week. And I think the lockdown basically was not instituted, so it was basically abandoned. We had no national lockdown. This is to ensure that I think these recommendations, although it was rapid, but it brought quite a lot of benefits to inform the government on how to manage the COVID-19. With that, I would want to basically say that what we are currently doing at the moment is now to look at how do we now put up a recovery plan. And this recovery plan, we want to emphasize on all sectors that we think are important, the healthy, the social protection, macroeconomic stability, protection of jobs, but also the social cohesion. As I think the UNDP say, can we now turn greatest reverse of human development into historical leap forward? There is no time to get back to normal. Normal was a world steeped in inequality and climate crisis. It is now time to move beyond recovery. A sustainable, inclusive, and resilient future is required. So thank you so much for listening. Thank you.
Well, thanks again, Doc, for that. I think you've just made the 12-minute mark, and I want to thank you once again for that very valuable presentation. I think with regards to the methodology, it's always difficult to do a cost-benefits analysis of saving lives. And I think one of the difficulties that most countries have had to grapple with, especially us here in Africa, is the delicate balance of really trying to strike between saving lives, as I indicated, by flattening the curve, and hence the restrictions are imposed, and of course curbing the impact on the economy. And we know that with some restrictions, especially those with regards to gatherings, can contribute quite significantly to the virus, especially having super spreaders in this regard. But thank you so much for that very insightful presentation. We now move to the last presentation, and we're going to try and be swift. I'm going to ask, speaking on governance management in service delivery of COVID-19, I'm going to ask Mr. Bongani Matomela, who is a program manager responsible for governance at UNDP, that's the United Nations Development Program in South Africa, a British Cheveling scholar who holds a master's degree in public administration from the University of North London and has 25 years of experience in the public and developmental sectors. Mr. Bongani Matomela has worked in the NGO sector, the government and international development agencies in various capacities, including as a community development worker, a researcher, a project manager and consultant in service delivery management, and a senior manager in government. I want to welcome you, Mr. Bongani, and give you the platform to speak for the next 12 minutes. Thank you very much, sir.
Thank you very much, Chairperson, and good day, colleagues. My name is Bongani Matomela. I'm the program manager for the United Nations Development Program in South Africa. Chairperson, if maybe I can share my presentation with your permission. There we are. We can all see it. Thank you. Thank you very much. I think as the United Nations Development Program, under the leadership of the UN in South Africa, at the onset of the declaration of the state of national disaster, and this was around the middle of March this year, and we anticipated that there will actually be more measures that are going to be put in place in terms of restriction. So we decided to embark on a study to basically look at what would be the social and the governance impact of the restrictions and also of the pandemic itself. So the studies really was around looking at the social systems and the governance structures, that were going to be impacted by this declaration. And I think our view on the report is basically that we're sort of taking a positive attitude that says that it's about strengthening and going forward is how do we strengthen these systems and these responses in the event that the country, is faced with a similar situation. So essentially, we're basically looking at that and we also acknowledge the fact that there was a lot of interrelatedness, between the social and the governance dimension. Of that. So this was really an impact study, and we focus on levels 4 and 5, of the restrictions, and we're really looking at the epidemiological and the health implications, and also a bit of an overview of what was happening globally, regional, and also national as well. We also were seeking to assess the disaster management framework or structure that we actually put in place. How decisions were actually being arrived at, and what was actually being put in place. But also more importantly was to look at the social and the economic impact, of the lockdown on the life of the South African citizens, and everybody who was in South Africa during that time. And as a result of that, we sort of developed this report. But also critical for us is that we've actually drafted a policy brief, which is really a synthesis of some of the issues that are coming up, both from a health point of view, from a social point of view, and also from a governance point of view as well. And in that policy brief, we are beginning to say that these are the possible policy consideration basically going forward. And in fact, one of the things that we're doing now is we're trying out to set up a sounding board. People are going to advise us on what we should really include in the policy brief, but also how to ensure that some of those things are taken forward within the structures of government as well. So we're trying to set up a reference group to advise us in terms of that. So as I'm saying, that the study objectives was really to look at the capacity of the state, in terms of the management of the containment of the spread of the disease, especially the extent to which that was affecting the most vulnerable groups. We're also looking at the social impact of the extraordinary measures that were taken, because this was unprecedented in South Africa. We're also looking at the state's capacity as well in terms of response and recovery as well. And towards the end, then we're beginning to throw what we think are some of the lessons, that can actually be learned, from this impact. In addition to the desktop analysis that we did, we also set up a reference group, that was made out of some key people from the UN agencies and also the people from government as well. And I'm glad to indicate that some colleagues from the Department of Social Development were part of that group, advising us as we were undertaking the studies. We had also colleagues from the National Disaster Management Center were part of that as well. We also undertook a survey in May in Gauteng, KZN, Eastern Cape, and Western Cape, just also to get a sense of the pulse of the people, in terms of how this lockdown was affected them. We're working with the Red Cross, in doing that with the volunteers. We got responses of about 1,700 to the questionnaire that we administered, and we've taken these insights from this survey to basically to inform our emerging report. I think some of the things that we're saying that in the policy overview is the need to really review the effectiveness of the disaster management response and the governance arrangements that we actually put in place. And I'm going to elaborate a bit more later on that. So I think that is the one thing. But also I think the other thing in the policy overview is the fact that South Africa needs to find very fast and effective ways to deal with the health, economic and social impact. And we picked up that there's a lot of correlation between the health, economic. COVID-19 is not a health crisis, it's also an economic crisis, it's also a social crisis as well. But also the impact this had both on citizens but also on non-citizens as well. I think the issue about the need to ensure that we begin to attend as a country, South Africa, to the needs of the most vulnerable members of society is a very critical thing that is coming out very clearly. The other critical thing was around the cushion and the provision of safety nets for workers and small business owners where very affected by the pandemic in terms of their cash liquidity, but also in terms of their income support as well. I think they need to begin to look at those things as part of social and economic policy as well. And the other critical thing is around the issue of social cohesion and strengthening social cohesion. At the beginning of the crisis, there was a lot of social solidarity, but I think towards the end, I think as the effect of the restrictions were hitting hard on people, there was a bit of discord and a bit of public unease basically about it. So I think that's some of the things that we picked up. On the health system's readiness, I think the real thing about the need to look at the health system readiness in terms of the response that we actually that was actually put in place. I think there's a need to actually to look into that. The review of the surveillance systems that were actually put in place, I think something that from a policy point of view that needs to be taken into account. The streamlining of protocols, especially as it relates to the provision of support, especially to the front line workers in the healthcare sector, particularly women healthcare workers who were the most affected by, I think, by the pandemic, as workers, but also as people who are running households, at community level. And I think one of the things that we're also saying that I think South Africa needs to think about how we can initiate some research as to why was South Africa the most affected, the worst affected country in the African continent. I think it's something that, not much has been said about, but I think it's something that we think that it needs to be taken into account. The issue of ensuring that you balancing when there's a crisis, you balance the need for continuity in terms of your regular health and social services, whilst you are also responding to the challenges of the pandemic as well. And finding that balance is just not only South African problem. It was countries were struggling basically with that, and they are still recovering from the impact of that in terms of how do we then go back and provide normal services as the pandemic in some cases, the cases are going down. I think the issue about the capacity of the healthcare system in terms of the healthcare workers and the capacity of the health infrastructure to absorb the challenges as well of the crisis as well, I think is something that needs to be taken into account. The other critical thing is around the gender dimension. I think as I think DDG mentioned at the beginning, the gender dimension of the crisis, is something that really needs to be taken into consideration, because it's something that has come out quite very, very, very strongly. I think, again, the issue about capacity of the resources of the healthcare system. I think the issue of the preparedness, in terms of detecting of the new diseases. How do we begin to put in place mechanism to ensure that we can do that, and the clinical manifestation thereof. But also how we can monitor the evolution of the diseases to society as well. I think it's something that we've actually picked up as something for consideration. They need to train, I think, healthcare workers, in terms of dealing with the new challenges about that these pandemics or these diseases are going to be the order of the day. How do we begin to prepare our healthcare system, but also the workers as well to be able to respond to that? I think the issue about ensuring that there's access, to protective equipment, I think it was a big issue as well. But also, I think the issue about, South Africa's role, in terms of its mechanism, institutional mechanism that it put in place to respond to the disaster. I think on the social impact, I think again, and I think these are the issues for social policy going forward. The issue about looking at social relief measures, the extent to which they were adequate, especially as they relate to the most vulnerable children, women, and people who are actually unemployed. I think there needs to be a discussion about the basic income grant and the modalities thereof, and there's a social policy issue as well. I think the issue about communication as well, in terms of the restrictions, I think there was a big issue there. I think it's something that needs to be taken very serious, especially around maintaining public trust and confidence, over a period of time. And I think the whole issue about how then do you make your public services ready for this new situation where services are not going to be made available in a normal way. How do we make your system ready in terms of infrastructure, your technology, and all of those things is very, very critical. The issue about support, targeted support, especially to people in the informal economy, including foreign nationals as well, because at some point they were forgotten, in the world thing. I mean, the focus was very much on citizens as well. I think those are some of the things that, from a social point of view, we need to take into account. I think the pandemic also exposed, the disparities in the education system in terms of some children had access to other forms of learning, others didn't have. How do we make sure that we actually address that? The issue of gender, I think, was quite very manifest in terms of this thing. The other issue around the social impact that, we actually picked up is the whole thing about the human rights framework. South Africa has got one of the most revered constitutions in the world, but I think COVID and some of the restrictions put into question the extent to which, the human rights framework was actually followed to the latter in terms of the spirit. So I think that is the one thing that we know that there were cases, where I think there was a bit of an overreach, in terms of the management of the restrictions. And I think the whole issue about resilience as well, and as I mentioned, building social cohesion in a post-COVID period, I think is something that I think is very critical. Some of these things I've sort of mentioned access to online environments, for education for children, issues of the GB as well, and also the issues about ensuring that the frameworks that we put in place are actually able to respond, to the needs of the most vulnerable members of society. I think something critical. I think on governance, I think one of the things that we are saying that there might be a need to consider some review of the disaster management response structures. And in that regard, we're working with the Disaster Management Center to basically look at what was the response and what could be done basically better, but also to prepare for early recovery basically as well. I think the planning frameworks and systems in government need to be relooked at. It can't be business as usual. We can't continue, to plan in the same way, as a country that we're actually planning. So I think there needs to be a relook in terms of that. I think the capacity of local government is one thing that we picked up that needs to be looked at, because local government was at the core phase of the response, and there was varied capacity, in terms of being able to implement the responses, water supply, and ensuring that everything was being done. The issue about the restrictions and the powers that we allocate to the police is something that we've also flagged up. And also, I think the issue about creating an enabling environment for Chapter 9 institutions to undertake their role in terms of monitoring and reporting, and I think is something that we need. And that is probably related to the point that we are saying about a whole of society governance approach, to how you manage and we respond, to crises like this. I think it can't be only government. It must be society. It must be civil society. It must be other including society, basically as well. And I think the other critical thing, we're saying that in the post-COVID-19 environment, I think there needs to be a comprehensive, across-the-board review of how the public service will need to gear itself to be much more agile and innovative in terms of how it is going to be doing things and delivering services. The role of local government is very critical. The role of non-state actors as well, is something that we flagged out. I think it needs to be rethought and maybe to be relooked at, because government alone, is not going to be able to manage and respond to this kind of pandemic as well. I think the issues about the balance between ensuring that people protect themselves and enforcing the regulations, I think, and because there are potential consequences for abuses of power if that is really not monitored. I think it's something that we think is very critical from a governance point of view. And I think the most critical thing around the government is the fact that the impact of the regulations have differentiated impact, especially on women, girls, and other vulnerable groups. So policy needs to be tailor-made to begin to realize that there may be differentiated impact in terms of the disaster management regulations that are actually put in place. So, and hence one of the recommendations that there needs to be a bit of a review and a re-engineering and look at how the response can actually be better managed and how the regulations could be crafted in such a way that they take into account this differentiated impact. So basically, I think the summary around, I think what COVID-19 has done is basically to say that, there are certain choices that I think South Africa, but also other countries in the world needs to look at. The country, we can all be in denial, like an ostrich, we bury our heads in the sand. Or we just, in a sense, just continue as usual. We just mark it through as best as we can. And that's really entrenching a culture of mediocrity, in how we manage things like that. Or we can be very indecisive. We kick the can down the road, hoping that the future will take care of itself, and then we return to pre-COVID-19 practices. And I don't think that's the choice that we want to make. Or we can then decide that let's take the flight of the flamingo, we craft a positive outcome and path, and we take off. And one of the things I've actually shown in this presentation, this is like an image of how the flamingos take off, and they have a destination, they've crafted a positive outcome, they know where they are going. And I think perhaps that's a choice that countries need to make as countries begin to recover from this COVID pandemic. Thank you very much. Sorry for overstepping my time allocated. Thanks.
Thank you very much. Thank you so much, Mr. Bongani. I think a brilliant lesson learned there. We don't want to be ostriches. We want to be flamingos. So we'll take the flight of the flamingo. Thank you for that input. I think you've highlighted the important connection between a government and its people, and through service delivery. And what's happened through COVID-19 is that we've actually been building a social compact amongst government, private sector, civil society, and other related sectors of society. That's what we've been doing without even knowing it, and I think it's a fundamental thing to do. And of course, the role of intermediaries and enablers in society is fundamental, particularly civil society and the private sector. That element of collaboration is fundamental, and I think we've seen a lot of it happening during COVID-19, where people are holding hands together towards one common goal, and that's ensuring that we try and reduce the spread. And of course, whilst doing that, assist in terms of ensuring that we avoid challenges such as food security, and so on and so forth. So I think the social policy recommendations are important to engage with, and we must further that discussion. And I think the value of this study was that it placed South Africa's government under the magnifying glass during the worst crisis. It can contribute immensely in preparation for a second wave and future disasters. And again, the value of these conversations are fundamental. It's really testing the ability of government. Well, the COVID at least is really pushed us towards testing the agility of government in responding to shocks such as COVID-19. Now we go to our discussant this afternoon, ladies and gentlemen, and this is. We are going to have Dr. Donation Bigai, who's from Kenya, Dr. Bigai is a population specialist and data expert with vast experience in research capacity building, knowledge translation and monitoring and evaluation of development programs in population and health. In Africa. He's currently president of the Union of African Population Studies. It is a great honor to welcome you, Doc, and let me give you about 10 minutes or so that we can entertain some questions after you've engaged or given us a bit of insights around the presentations that were made. Thank you very much, Doc, and over to you.
Thank you very much. I hope you hear me very well.
Yes, we can hear you perfectly well.
Okay. So let me thank all the organizers for offering this opportunity for discussing this important issue for Africa, and also for inviting me to discuss this session. I think the world is going through a very difficult time due to this pandemic, and you are definitely not yet done with it. And if you go by the latest development in terms of increasing new infections, death, confinement across the world. And for Africa, I think revisiting the role and importance of demographic dividend in the context of COVID-19 is all more important. That demographic dividend has been seen in recent years as a likely pathway towards sustainable development for many countries, but also because the pandemic arrived at a moment when prospects for many African countries were promising. Let me first say that the presentations complement each other by addressing different aspects of how best to ensure the pandemic does not annihilate or reverse the gain that South Africa, Uganda, Malawi, and by extension Africa have been making towards setting conducive environment for the realization of the demographic dividend. In South Africa, we heard about the need for strengthening governance and social systems responses to COVID-19 through the gender lens or human rights lens, based on the assessment of the disaster management governance structures, but also decision-making processes on one hand, and an assessment of the social economic impact of the mitigation measures, including lockdown on citizens on the other. We've also learned about how long-term data collection mechanisms, such as the health and demographic surveillance system based on science, innovation, and technology, can be harnessed to respond appropriately to the COVID-19 pandemic. In Uganda, the focus was on the challenges faced in delivery of sexual and reproductive health services, and how organizations and communities are adapting themselves to safeguard the gains but also achieve their goals during this trying period. While in Malawi, I think the focus was on the difficult trade-offs that policymakers have to make when it comes to finding the best solutions or strategies to the crisis by looking at the opportunity cost of the different measures put in place. Here, the question that asked is whether do the benefits gained through the measures put in place, such as lockdowns or school closures, outweigh the losses in other sectors such as education and productive. I believe this is definitely not an easy debate in the saving lives or building the future of younger generations, and perhaps we are very far from knowing the more precise response given the current situation for many countries. I think beyond service delivery, this presentation taken together address concerns and issues that are key to the demographic dividend, and as they are in line with some of the main pillars like health and well-being, education and skills development, economic reform, or job creation and governance, for example. In general, COVID-19 has already had a larger impact on our way of life, including the economy, environment, housing, food security, tourism, migration, health, education, among others. And this impact have and will no doubt exacerbate the vulnerability of many subpopulation groups, such as young people, residents of informal settlements, women, the disabled, elderly person, and children. And I think specifically in terms of education, it's clear that the pandemic is threatening the progress that African countries were making in democratizing education, reducing the gap between boys and girls in terms of access to education, which in turn help in keeping girls out of early marriage, help them accessing gainful employment, and addressing sexual and reproductive health needs. I think this is clearly a sort of setback in terms of gain for women's empowerment, and as such, government need to refocus on it amidst many other challenges. And in general, although not backed by undisputable evidence, it has been suggested that Africa may have been less affected than Western countries, for example, because of its youthful population. But again, the fact is that the same youthful population may have lost opportunities in terms of education and employment due to the pandemic. In other words, the pandemic is somehow hitting where it matters most, than youth, one of the biggest assets the continent has in terms of achieving the DD. How can Africa reap a DVD from its youth badge when its ability in putting in place appropriate strategies and programs and delivery is curtailed by the pandemic? Data from UNICEF, for example, show that more than 1 billion children are at risk of falling behind due to school closure. Although countries have been implementing remote education programs, not all children, especially girls or those from poor areas, are being hit due to lack of internet access, no computers, TV or radio at home, and therefore amplifying the effect of existing learning inequalities. Clearly, many governments need to go back to the drawing board to ensure gender gaps in terms of education do not widen. In terms of health, as seen in the example of Uganda, key health programs may have been suffering from the fact that governments are diverting resources to fighting the pandemic, or the pandemic itself has affected the proper implementation of existing programs. In general, I think the concern for many countries that the COVID may reverse the gain made so far in terms of child survival, mother's health, access to voluntary family planning, SRH, and in general, due to the related measure put in place on one hand, and in ensuring healthy lives through the life cycle, given that it may have diverted attention from other key health issues, such as pneumonia, malaria, TB, and others. So evidence that hundreds of millions of women, for example, in countries as the ones in Africa may be having a need for family planning, but also suffering from gender-based violence to these issues. In terms of employment and creation, we've seen loss of jobs and reduced productivity. In the case of informal workers, is said to be even worse. In addition, many governments may have lost the ability to create more jobs because resources and other key inputs may have been diverted to fighting the company. Available data from ILO and women suggests that seems to target that young people and women may be disproportionately affected as they work more in formal activities and their skills. One would wonder whether African countries are in a position to provide robust stimulus packages, strong focus on women and other as part of the economic reforms and recovery mechanism. In terms of governance, right, let me say that so far the attention that good governance, accountability has been received in DD conversations has not been commensurate with its importance in the realization of DD. COVID-19 provides here a good opportunity to correct this anomaly. The example of South Africa and many other countries is telling, as indicated by the presenters. In general, many countries have had to count first on themselves to sort out the issues by finding appropriate solutions using their own resources, and their good governance matters. Although the challenges you have seen in some countries in terms of the management of the resources dedicated to the responses to the COVID-19 call for a cautious optimism, one can believe that the presence of dealing with COVID-19, experience of dealing with COVID-19 can help African countries foster transparency and accountability in the utilization of the scarce resources or in service delivery, while enhancing also trust in the institutions and promoting more participatory decision-making processes. Now, coming to data, which I believe is the elephant in the room, and this has also been emphasized by one of the presenters at the beginning. The value of data and information cannot be overemphasized in period of crisis, such as the one the world and Africa has been in since December 2019. In such times where the right decisions must be made quickly and the right time and place, authorities need systems that can help them collate, analyze, and translate data in simple to understand information for emergency responses, policies, and actions. Such systems enable policymakers, planners, and healthcare providers, communities, and even others to track progress towards fighting the disease and identify setbacks while developing corrective measures and actions. Early lessons from countries show that one of the key challenges hindering local response is the lack of data national, but more importantly at local level, to help them assess the risk and make quick and informed decisions to contain the propagation of the virus. I think scientific advisory groups working with government at national and local level not getting really the timely and relevant data information for the actions. And even countries and even urban areas that are more in terms of infrastructure do not always have this kind of systems for addressing the issue. And the pandemic has clearly shown a widespread lack of standardized system for systematically and efficiently managing basic statistical data that need to be collected and widely disseminated in a pandemic situation. And even though the reality is that all countries, including the developed countries, have had difficulties getting accurate statistical data on the COVID-19 pandemic, the situation in African countries in terms of data production and use, which has been already poor before the pandemic, is definitely worse. As such, I believe the data revolution that has been called for since the adoption of the 2030 agenda has to be definitely accelerated. And African countries need to invest in their data systems without further delay. Addition, I think the severe restriction that were imposed on population movement, pre-lockdown, have adversely affected field data collection activities with major survey programs having suspended their field activities or finding other ways of data collection, which often present high risk of poor data quality. And much emphasis has been put on using technology to help resolve the issue of data production and use. But again, technology has its own challenges, including issues related to confidentiality, privacy, liberties. In fact, despite the positive potential of this technology and data innovation, it's important to understand for many African countries the potential ethical, legal, and socio-economic ramification that could emerge from its use of technology in emerging contexts, especially to safeguard rights and ensure inclusive approach to response and recovery. So there are clearly some issues of data governance that need to be addressed in such situations, and it's important for government and other stakeholders to address them in the response and recovery packages. It is, however, great to see from the experience shared that that systems such as health and demographic surveillance systems are playing a key role in supporting local authorities in their response at different levels through generating appropriate evidence for monitoring responses and assessing their impact. I believe this is an example then for many countries, and in general, the discussion here should also about how countries can reinforce and better and integrate data systems such as HGSS among themselves in it, but also with other existing systems or the wider national statistical system to build integrated systems to full interoperability such that they play a bigger role in such situations that we are in. Perhaps our colleagues can share more light on the lessons learned and challenges running such systems in such difficult situations. But even if the right data exists at the right time, the other issue worth mentioning, I believe, is only the challenges related to making decisions in such situations. The question here is, are we always able to make the appropriate decision during those emergency situations? Or is it a matter of trying and trying? Do decision makers get the necessary time to reflect on what is offered to them and action them? Is the necessary dialogue between researcher and expert on one hand and the policymakers possible to enable an efficient decision-making process? I believe there is some room for reflection post-COVID to make about evidence-based decision-making processes in this kind of situation. But perhaps our colleagues from AFIDEP are thinking about it and may have some ideas to share. So to conclude, I think overall, this example in this presentation shown today demonstrate the extent of challenges that African countries have faced for service delivery during the COVID-19 situation, and the amount of work that needs to be done in terms of policies, investment, and action to build better, safeguard the gains, and also maintain the cost towards achieving demographic dividend. It is not an easy task, as one can see from the numerous issues to address in all sectors, in all the complex interrelations, but I believe the resilience shown so far by countries and the population is a first good sign and step forward. So thank you again for all the presenters and to all the organizers for providing this platform for this important discussion. Thank you. Over to you.
Well, thank you so much, Doc, for that sort of wonderful wrap up in terms of the presenters that have presented. I think this is very useful information that indeed we should consider looking at and engaging on in a much more in greater depth rather. So I think on that note, what I'll do is we've got about 9 minutes left only, but I'll best to try and quickly deal with here. Yeah, different as it is. Yeah. Okay. No, thanks. There are questions that have been asked for Dr. Hurst, and the question to you, Doc, is due to the difficulty of social distancing in some of our areas and the close quarters living in arrangements, etc., it might be that the antibodies are much higher in the population. Are there any serology studies planned for to ascertain the prevalence of COVID-19 infections in the general population in particular populations? I hope I've been able to ask that. Let me quickly ask the others, Doc, and so that we can get overall responses. Just a quick question for Dr. Annette as well. Why do you think there was an increase and at what point during the lockdown or as it gets? Oh, sorry. Let me ask that question again. Why do you think there was an increase, and at what point during the lockdown, or as it gets eased? Normally, how the reporting of SGBV in Uganda in Uganda. I'm not sure how to. Oh, okay. Normally, how the reporting of SGBV, sexual and gender-based violence in Uganda, and then the question to Dr. Nagoli: how can we lower AIDS deaths? That's a question for you, Dr. Nagoli. And the last question for Dr. Joseph. It's interesting to see the modeling done by Malawi. Was similar modeling done in other countries? And when will there be an analysis of actual impact of COVID-19 given the different approaches across the region? I hope I've been able to ask those, read those questions adequately. Let's start with Dr. Hurst and then Dr. Annette. Let's try and keep maybe our responses to about a minute or so if possible, please. Thank you, Dr. Hurst.
Yeah. seroprevalence studies are really important. Firstly, because there's a large proportion of asymptomatic cases, and that really will tell us the broader impact of it. As I mentioned, that SAPRIN is definitely planning and seeking funding, in fact, to do seroprevalence surveys within these populations. But I also know that the Human Sciences Research Council in South Africa is also in the process of planning a national seroprevalence survey.
Thank you very much, Dr. Hurst. Dr. Antoinette, the question to you.
Thank you. Gender-based violence, how I would put it is, with the lockdown and the loss of jobs, there's increased pressure due to inability to meet the family demands, including basic needs amidst the resource limitations. And that is one of the major causes of gender-based violence. And of course, as more people, as couples spent more time together, cases of what would have been hidden infidelity also came up, leading to gender-based violence. That's how I can put it for now. Reporting of GBV, yes, we have the legal framework, but we also have, in terms of injuries to the health facilities. Now, that is what we can go by. But of course, usually with the gender dynamics, most of the cases go unreported, especially in the legal line or seeking legal redress. Thank you. Over to you.
Thank you very much, Dr. Nett. A question for Dr. Nagoli around how do we lower AIDS deaths, particularly if there are comorbidities. That's the one for you, Doc.
Thank you so much for that question. I think the reason is quite complex. Basically, because it could be, yes, data, we can't rule out the issue of data, but I think the data that we used in this case was real-time data. But I think maybe the explanation could be that we're talking here about short-term restrictions, I think of a maximum of 6 months. So the reason could be that I think at that time, if, for example, if somebody had the virus, it may not have developed into a disease. So that's why it was showing some low figures of death from HIV/AIDS. Maybe that would be the best explanation than the data itself. So in terms of the other question on whether this kind of analysis has been done in other countries, I'm not very sure of other countries that have done it. But I think maybe this is something that we need to look into. Probably through these discussions, we can look at having a more broader, maybe country comparisons, as I think we're anticipating the second wave. So that would be my short answers. Thank you.
Thank you very much, there, Doc. The last question then goes to Dr. Joseph.
Yeah, I think I tackled all the answers. I don't know if the last question was about what?
No, perfect. No, thank you so much, Doc. Thanks for that. There is a question, there's a burning question from somebody who's in the meeting. It's Mr. Chimwete. Let's give you a chance quickly, and we'll try and keep it to about 30 seconds or so. We're still going to strive to conclude at 5 p.m. In this regard. So can we give Chimwete, if you're still here? Okay, I think we've lost him. So I think those were the set of questions that were asked. Let me, at this juncture, take about a minute or so just to deal with about 2 or 3 things. Firstly, let me say that I think we've, I see Oliver Zambuko. Let's give Oliver a quick chance. Oh, Oliver.
Thank you. Yeah, thank you, Chair. Mine is quick. Just to all presenters, maybe anybody can tackle the question. My question is, given COVID, are there any opportunities that you observed from different countries where countries will be able to have leveraged on COVID in order to achieve the universalization of health coverage in these countries? Thanks.
Thank you. Who is that question posed to, Mr. Oliver? Specifically?
Anybody, anybody can tackle it. Thanks.
You are getting us into trouble because we will go into extra time. But let's see. Maybe we can ask. Maybe we can ask Mr. Bongani to answer that one. Mr. Bongani, you keen on that, sir?
Can you hear me?
Yes, sir. Please go ahead.
Yes. No. Thank you. Thank you very much, Pascal, about it. I think to answer I think the question, I think maybe more general, and I think that's a general trend one has probably observed in most countries. I think one of the things that I think we're picking up, I think, is the whole thing about leadership matters, and this is not just leadership, from top down, but I think leadership at all levels of society, and in most countries where I think there has been successes, I think the issue of leadership has actually been a very critical sort of a component. And I think related to that, I think, is the issue of recognizing, I think, the intersectionality, of health. This having been a health crisis, but also the social dimension basically to that, and also the institutional dimension. And in fact, this is basically what, through our analysis, we're actually trying to assess. But you'll find that in most cases where I think the health response has been quite very effective, it's almost been a combination, of that leadership at all levels, of society, and basically sort of a government. I think one of the things, I think for South Africa, for example, we sort of did a bit of a in-depth case study on Gauteng. And one of the things that we realized that the Gauteng model, of basically trying to say that, we need to strike a balance between responding to the crisis, but also continuity, basically, as well, and how government coordinated itself at that particular level, both provincial, district, and actually at local government sort of level. In a sense, everybody was thinking from the same hymn sheet, to use that expression. So it's kind of one of the indicators that we sort of picked up. But I think something that we're quite very keen to study further, in terms of some in-depth analysis, basically, of it. I would probably, and maybe other colleagues can chip in. Thank you.
No, thanks. Thank you very much. I think you may have covered all the colleagues. Accordingly, I want to, at the risk of losing people in the session, there's just two more things for us to do. I want to just make two fundamental points, and then I want to hand over to Ketani to deal with some administrative announcements, etc. Firstly, let me really appreciate the coordinators of this session for inviting me to be part and parcel. I've learned a great deal in this session today, and I think the more we have sessions of this nature, the better we are, the better it is for us to share best practices and engage with other countries to get a sense of how they've handled or how they've managed through the pandemic. And I think this is useful information that we need to take through and really look at some areas that we could even consider implementing in our very own countries. But of course, the important thing is that it must assist us towards the policy decisions that we make as member states. And I think working towards the last session, it will be important that we sort of package all of them quite nicely so that we are able to leverage on some of the information and wisdom, of course, shared by our panelists today and our discussants. And I want to really appreciate that. So that's the first point. The second point is really to say that, what we're dealing with here is an invisible enemy, of course, as we all know, and we're having to deal with the effects of that. But also, we're not sure what's going to happen in the next few weeks, months, days, and so on, with the possibility of a second wave. And I think the demand for our services and the demand for for our services and social protection services in the main, as well as social ills, are on the rise. and increasing on a daily basis, which makes it very difficult for us to be able to deal with this particular war in the same way in which we did previously ahead of the war, before the war did. So we need a different set of skills in some areas. We need a rethinking in some areas in terms of how we're going to grapple with this new normal. And I think some of the information shared today, particularly around the value of data and information, etc., and some of the case studies from Malawi and Uganda has been really useful to this effect. I just want to say that I think as demographers and statisticians, a lot of our work really focuses on what's happening now and the current issues. And one of the things I think we need to think about is looking much more at future scenarios and modeling on the basis of our scientific work to better inform evidence-based decision making and policy making, of course, for the future. And I think if we're able to really consider some future scenarios to see what the future may look like, and predicting, if you like, it would assist us greatly in terms of making these decisions that are informed by the science and the data that our colleagues have worked on. So, at the risk of losing anybody else, let me stop. And let me ask Ketani to come and deal with some administrative matters. But thank you once again. Thank you very much, colleagues.
Thank you so much, Acting DDG, for the work well done. And thank you also, colleagues, for taking time to participate in this webinar. It was very, very engaging. The presentations that we had were very exciting and informative. Just one last announcement. Next week at the same time, we'll be having another exciting webinar that will look at actions that our country has taken to adapt its policies and programs for the demographic dividend in the light of COVID-19. So I would like to extend an invitation to all of us to be available for that session. And before I close the meeting, I would like to just thank also our partners who were with us when we were conceptualizing this webinar, and for all the background work that happened behind the scenes. Without running at the risk of mentioning some names and forgetting some, I'll just end there. Thank you so much. We'll see each other next week. Goodbye. Thank you very much, colleagues.
Thank you so much. Thank you.